I should be able to have music play while I'm live. Like instead of playing it in the background, if your music is too loud in the background and it's recognized by the copyright filters, they actually will ding your account. So TikTok needs a way to have music playing in the background. Maybe they do, and I just don't know about it. Hello, EMT Mini Schnauzer Mama. Hello, everyone. All four of you that's joined. Maybe it's too late to go live. I don't know. I'm just trying to kill the last about hour and a half of work. Highly unlikely, knock on marble, highly unlikely I'm going to get a call. What article would that be, Judd? About nurse practitioners in emergency care, bashing nurse practitioner education. I did not see it, but I'm kind of over the hate on mid-level providers. They serve a purpose. Because I don't work 911, they're careful about assigning us calls as we approach the end of our shift. My shift is at midnight. It's right now it's almost 11 o'clock Eastern, and so it really has to be something serious, and the entire crew has to agree to take the call. So there reaches a point towards the end of shift where you start to feel pretty safe, but you still have a while to go towards the end of the shift. Been a while since you caught me live. Watched your podcast on YouTube yesterday. Great job. Thank you very much. I'm in the process right now of stripping the audio out of that so I can get it uploaded to Spotify and Apple. And I'll probably start just uploading all of my lives to my YouTube channel as well. Somebody had told me that, actually a bunch of people had told me that they like to run those lives or replay them like when they're just in the house doing stuff. So sure, why not? Have I thought about writing a book? I probably will write a book. I'm starting to take some notes. I'm just trying to figure out kind of what approach I want to take to it. You can self-publish on Amazon. It doesn't cost that much at all. I mean, it really doesn't cost you anything. So that's probably the route that I'll go. What would my book be about? Just my approach to EMS. Maybe do a little bit of myth busting, that sort of thing. Have some. It would probably be just a practical and pragmatic look at EMS. And starting right off the bat from how no one who enters a field is actually prepared for what they're actually going to be doing in the field. You go in thinking that you're going to be running emergencies, taking care of people with heart attack. When you come out of school, you probably think you're going to run COPD calls all day, sprinkled in with STEMIs and cardiac arrests and multi-systems trauma. And in reality, mostly you're just running to non-acute type calls, giving people a medical screening and sometimes reluctantly taking them to the hospital. And no one prepares any students for that. They just don't. And that is a disservice to the people that are entering the field, because they get salty very quickly because reality doesn't match up with their expectations. And that is on the school programs and the instructors for not literally just telling them what they're going to be doing when they enter the field. Imagine if you could just get your mind right before entering the field. Okay, I am a pre-hospital healthcare provider who is also prepared for emergencies. If you had that at the front of your mind, within 5 minutes of entering the field, you wouldn't be salty and bitter over people calling 911 for non-emergencies. Do I instruct in the classroom? I do not. That is just not the environment for me. So West Virginia's protocols were updated in a big positive way. That's awesome. Oh, including blood products. That's awesome. And surgical procedures incoming by 2025. You have my attention. What does that mean? Thoughts on narrowing the gaps between basic, advanced NRP skills and capabilities. And I think that we just need to get rid of the basic cert altogether. And it would be much easier to just separate AEMT from paramedic at that point. I mean, we're skills creeping so far into the EMT levels that we might as well just go ahead and just cut off the basic EMT. Surgical crikes and chest tubes. That's cool. I'm certainly open to a disagreement. Any advice on best learning ECGs? YouTube is your friend. There's so much good content on YouTube when it comes to learning ECGs. Akadoodle is a good resource. Keeping up with Dr. Stephen Smith's ECG blog is a good resource. And just, following your curiosity. Anytime you see something that's a little wonky, doing a Google search as well. Why cut off the basic EMT? Do you not feel it's necessary prior to becoming a medic? I mean, do most nurses start out as LPNs or EMTs? I mean, most of the nurses I know just went ahead and just became nurses. It's not necessary to have all these baby steps on the way to things. And it's not like, in the grand scheme of things, that there is an incredible learning curve between EMT and AEMT. There's a little bit of a step up there, but I mean, it is certainly not a massive gap. So why not just start people into the AEMT spectrum? And when I say that, it's not like I feel very strongly about it. Like, I'm not going to, go to college tomorrow and publish my thesis on why we should get rid of the basic EMT. I'm just inclined towards that way. I also think that the basic EMT position is kind of an invitation to a lot of people getting to EMS that really probably shouldn't. It allows people who don't have maybe this will get me in trouble, but I think a lot of people get into EMS because of the low barrier of the EMT. And they manage to just kind of keep working their way up after that when they really don't have the aptitude for it. And I think having a little bit of a steeper barrier for entry into EMS would do the field a lot of good. know too much now. We know too much to have a certification out there that doesn't have some of the diagnostics and abilities to rule in or rule out things that we're concerned with. And I think that we can give some of those things to AEMT. Good evening, sir, from a Huntsville, Alabama EMS dispatcher. Good evening to you as well. Most nurses do start as EMTs and paramedics, and I don't know what LVN is. Do most of them start there, or just do a lot of them start there? Like I said, I'm just kind of inclined that way. I'm open to changing my mind. I showed my medic your post on hospital wait times, and he agreed. The only thing special about AEMTs is IVs and a few meds, pretty much. Hey, I'm going to give you the attention you want, okay, Peanut? Hey, what a small world. You were dating my cousin James. How have you been? That land the way you want it? Looking forward to meeting you in person at Crash and Learn next week. Yeah, I'm really, really excited about that. That's one of my favorite conferences. That's such a unique conference. Personally, I'd say the low barrier is what got me in EMS the first place. Yeah, it's a stupid opinion that's not based on any prolonged amount of thought. And in all reality, I try to avoid positions like that where I'm just like, what's my first inclination on something, and I throw it out there. So I don't know. It's probably, like I said, it's probably a really shitty opinion. What is your opinion on AEMTs being allowed to give narcs? I'm fine with AEMTs giving narcs as long as they also can monitor that patient on the cardiac monitor, can monitor their end tidal, and have Narcan available. So, at that point, you might as well be a paramedic. Good evening from an Ontario, Canada paramedic. Good evening to you up there in the Great White North. LVN is an LPN. Ah, okay. Good evening, Craig from New Jersey EMT. Well, Craig, good evening to you. I am up in the northern part of the turnpike there. I'm from Patterson. I've learned to enjoy the low acuity. We get the people to the help, simple chart, SpO2, BP cuff. Yeah, that's the thing, is that there are so many people that complain about the people that have used the 911 system, but no one wants a bad call, right? They want a sexy bad call, like a cardiac arrest or a trauma or something like that, but no one wants like somebody who has like severe cardiomyopathy and is in cardiogenic shock and needs pressors, is in peri-arrest and you can hardly move with that patient until you stabilize them. Nobody wants that. And, they get so upset when they get any sort of a call that's going to tax them. But yet, shame on everyone for abusing the 911 system. You should speak at Tennessee's EMS Educator Conference. Well, all they have to do is invite me. I don't apply to conferences. It's not that important to me. Like I'd have other priorities. So when people invite me to stuff, I see if it'll work with my schedule. And if I have a way in to what they want me to talk about, and what I mean by that is you can't just say, hey, will you come to the conference and talk to us about, I don't know, about, pulmonary hypertension, unless I have something interesting already that I want to talk about that's related to pulmonary hypertension. I just can't force myself to make a PowerPoint on that. So if it works with my schedule, if I can kind of find the angle that I want on the topic, and they're going to compensate me. And when I say compensate, I don't mean make me rich, but I mean I shouldn't have to spend any money to get there, and I should come back with a few extra dollars in my pocket. FDNY EMS, EMT paramedic, has a promotion to firefighter. Thoughts? It should be the other way around. Like you're a paramedic and they're giving you some incentive to become a firefighter? Nothing wrong with having an opinion, the bossy paramedic girl says. That bossy paramedic girl says. No, you're right. There's nothing wrong with having an opinion. However, I have come to this place where I've recognized that I am not just one person now with an opinion. I'm someone with a modest following that has an opinion. And every once in a while, I've talked out of the side of my mouth, and it has come back to me somehow. It's gone out there into the social media abyss, and then spat back out at me, and I'm like, ooh. And I didn't even put any thought about that. I have to be really careful now with what I say and what I put out there. Oh man, all these comments are stacking up. Okay. I personally think we should do away with EMR and make EMT the minimum. Yeah, I mean, I guess. EMR, I don't know. I don't really have an opinion about that, actually. I work for the Holy Name Medical Center. That sounds really culty. Sorry. What's the call you dread the most pop up on your system? The call that I dread the most. I mean, I work in neonatal and pediatric critical care, so it's an actual sick kid that we dread the most. And our cardiac babies, what we call our CI babies, our cardiac babies, are the ones that, are going to induce the most amount of pucker factor. Or a kid that's in, some sort of respiratory difficulty that you already know by the information that you've gotten that they're not doing well and they're just sitting there right on the edge. Hello, Texas Medic. Way to go, delegated practice state. Perhaps steps in the EMT paramedic isn't the answer. Maybe we should use a sliding scale. That's an interesting thought, where you get in at a certain level and then you can kind of establish competency as you progress in your career. You become an AEMT, and you at some point you can establish competency at ECG interpretation, or you can establish competency at intubation. Yeah, I don't know. Am I coming to World? I was, but that has fallen apart because I have some other stuff going on. So unfortunately, I'm not. I am absolutely going to be there next year, though, because I think I'm going to be speaking there next year. Bergen County in the house. Oh man, I've spent plenty of time in Bergen County. All my family. I mean, I had plenty of family that lived in Bergen County. And I went to a private school. Well, you're probably familiar with Eastern Christian High School. That's where I went to high school. And half of my school, that's in North Halden and Passaic County, but half of the people that I went to school with were from Bergen County. I can actually suggest you to my director, David Blevins. He is on the EMS board. Why does that name sound familiar? I'm looking forward to all of you who will be at Crash and Learn, seeing all of you who will be at Crash and Learn. I'm going to be the fat guy. I say that because I was looking at myself in the mirror today. I mean, not like staring at myself. I caught myself and realized I had really let my weight get away from me. I've got a pretty good gut hanging off there, and I had made so much progress earlier this year. So I got very convicted today to get back out there and exercise and eat well. Good evening, Jacob. I hope you're doing well as well. I dislike emphasis on tech versus good clinical assessment. I think there's a whole discussion happening around me here. Holy shit, I got 40 messages? Oof. Ringers versus normal saline. I mean, if I could have the choice in every patient, I would just give ringers in every patient. I mean, it's a balanced fluid, so why not give ringers? But, in your sicker patients, for sure, ringers. King Airways versus ET tubes on field codes. Typically have multiple medics on scene at my department. Well, it depends on what the competency of your department is. If your first pass success rates are like 50%, that means that every other first attempt at intubating is going to fail, which means that you are really screwing around with that patient's chance of survival. So please drop a supraglottic airway. If your first pass success rates are like 90%, then absolutely drop that endotracheal tube, but don't empirically intubate everyone. Not everyone needs an advanced airway placed. I need to make a video on this because it gets lost in all this discussion that this isn't a hierarchy as far as like BVM ventilations, supraglottic airways, and ET tubes. Like there's not this hierarchy of airways where one is superior than the other, and then the other is superior, and then the other is superior. So you might as well just use the most superior one, and then as things go wrong, you keep descending back down to the least superior one. It's not like that. So let's say you have a 50-year-old who's playing tennis, has cardiac arrest in a tennis court, has immediate bystander CPR, right? And is presenting rhythm as V-fib. You have a really, really good shot of getting that patient back, maybe even on the first defibrillation, maybe the second defibrillation. A patient probably does not need an advanced airway place. Like, just bag the guy as long as, there's no, airway issues as far as like aspiration. He's not throwing up or anything like that. You can just manage that airway with just a BVM and an adjunct. But you get someone who, is a lot sicker and had an arrest, with the downtime of around 8 minutes or so, no bystander CPR. They look to be very, very sick. You need some sort of advanced airway on that patient, and based on your competency, that's going to determine what airway that's going to be, and you could probably make a case for either supraglottic or endotracheal tube. But then maybe you have someone who they are a CHF patient who ran out of their medication 3 weeks ago, ran out of their Lasix, and there's literally pink frothy sputum all over their mouth, and it's contaminating the inside of their mouth and all that sort of stuff. There's no question that patient needs an endotracheal tube. So there are a lot of factors that come to play in what airway you're actually going to place. So it's not a binary issue. It's not this airway or that airway, or this airway or that airway, or no airway or absolutely an airway. It is very situationally dependent. And the fact that endotracheal intubation is the gold standard isn't a compelling reason for intubating somebody, okay? But gold standard is not a compelling reason for intubating someone, because then all the anesthesiologists that are placing laryngeal mask airways in their surgeries are doing it wrong, right? So it is We just need to get better at identifying the candidates for the specific type of ways we're going to manage their airways. Holy crap, I got a bunch of messages. Kansas is allowing ambulance drivers as a second technician for very small counties. Oof. EMS needs to evolve to something better and bigger. Listen to my brand new podcast on YouTube. I talked to somebody who's trying to make that happen. FDNY thinks a firefighter is a promotion above medic, more money. The failures of fire department-based EMS. Yeah, that's a weird angle. Am I going to Jekyll Island? I don't know what that's about. I mean, I know where Jekyll Island is, but I don't know what's happening there. Roanoke, VA. I've been to Roanoke. That's a cool area. Chattanooga. Been to Chattanooga. Thoughts on the New Jersey system? It's just weird that the state has such a heavy hand in EMS in New Jersey. When am I coming to Ohio? Well, whenever I've been, if something in Ohio invites me to speak there, then I guess then. David B. is on TikTok as Handoff Medic. Okay, I think I follow Handoff Medic, but I still can't picture them. Tips for struggling provisionals. I don't know what that means. Enjoy your content. I learn a lot. Thank you. There's a service in my area where I did clinicals. They only carry lactated ringers. They do not carry normal saline. That's fantastic. There's almost no situation where you can't give lactated ringers. Now, if your patient is allergic to corn, they may not be able to be given lactated ringers because the lactate that is in lactated ringers is fermented on corn sugar. Most of the time, bystander CPR is ineffective. Citation required. Bystander CPR is one of the biggest contributors to survival in cardiac arrest in the U.S. I don't understand how that service can have LR only. It's because they like to rock, that's why. The Georgia EMS conference is on Jekyll Island. Oh, okay. You know what? I've never even heard of the Georgia EMS conference. And I'm going to be honest with you, Georgia EMS sucks. It is completely fragmented and regressive, and it's embarrassing. There's nothing good in Ohio. That's funny. Just hopped in. What are we talking about? I'm bored and injured. I don't know. Oh, there's Mike Verkest. Best educational EMS creator. Thanks so much. I'm trying to get caught up on messages here. What's your opinion on red dot skills? I don't know what that is. Does lactated ringers negatively affect coagulation the same way normal saline does? Yes. Hi again from Carolina. From San Diego. I just clocked into my first official basic shift. That's awesome. Good luck to you. Don't lose your enthusiasm. Hello from Jackson, Tennessee. Hello to you. Always love your vids, even if I sometimes give you some mess about them. I don't know what mess that you give me, but that's fine. You know, you should be giving people like me mess about them. Like, I need to be kept on my toes just like any other creator needs to be kept on their toes. I'm just one guy with a phone, right? So, which though is though why I try to be very, very careful about citations and not saying things that I cannot offer a citation for. But you should be challenging me. You should be pushing me. Absolutely. I believe the pH is 5.6. It's 5.5. Well, there's a range for normal saline. So yes, the pH is 5.6 for normal saline or close to it. LR is 6.5. That's correct. Thank you, Craig, the Canadian. Hello, retired EMT crew chief, 23 years from North Carolina. What part of North Carolina? I gave you mess about removal of pre-hospital RSI. It does not ring in any bells. Like you're advocating for removing pre-hospital RSI? Because I'm certainly not. Is there somebody out there advocating that we remove pre-hospital RSI? Charlotte, North Carolina. Okay. I lived in Wilmington for 20 years. Hi from Niagara Falls, Canada. Hi back to you. I've been to Niagara Falls. Recently saw a doc's video stating he thinks you shouldn't be able to do RSI as a medic unless you can surgical crike as a backup. Well, I mean, there aren't many medic systems that don't have some sort of surgical crike, even if it's needle crike. But that's stupid because supraglottic airways are a thing. But I guess if you're trying to RSI, then you actually are trying to secure the airway. But, if you're using rock, which you should be instead of sucks, and you don't have, so you don't need a surgical crike if you have Sagamadex, which is the reversal agent for rock. So at this point in time, anyone who carries rock uranium should carry Sagamadex. The Tennessee EMS board was actually considering not letting medics intubate anymore. I mean, what's your state's first pass success rate? If services aren't going to keep their medics' competency up, then why should they be allowed to intubate? But instead of doing it statewide, though, regions should have to apply, or counties should have to apply for a license to intubate, or however they want to term it, and prove that they deserve to. That seems like a reasonable compromise. Not just well, if this county sucks at intubating, then the whole state can't intubate. Do I think AEMT should be able to RSI? No. An alternative to RSI, which I've used, is intentional narcotic OD followed by Narcan titrated. That's a little weird way of saying drug-assisted intubation. But why would you... Oh, I see what you're saying. Dude, seriously. I'm not even going to address that. Question, would you tube a child with a pneumothorax? No? Well, I mean, I wouldn't tube a child simply because pneumothorax. And in all reality, not every pneumothorax even needs attention. It just depends on how progressed it is. Like a 15%, 10 to 15% pneumothorax probably doesn't need any intervention. It probably just needs to be monitored. It really just depends on how it's impacting the patient before you actually even intervene in a pneumothorax. Simple pneumothorax doesn't really need an EMS intervention other than supplemental oxygen if the patient is experiencing increased work of breathing or hypoxemia. As that progresses, then we start talking about needle decompression or finger thoracotomy. And then beyond that is, when we consider whether or not it depends on what side the pneumothorax is on, but you can actually, like if it's on the right side, on the left side, you can right main stem the patient so that you don't keep exacerbating that pneumothorax. Hello, Thomas. My department requires push-dose epi to be drawn up if we're RSIing to avoid the patient crashing. Well, I think that's a great strategy, but remember to resuscitate before you intubate so that you're not on the verge of that patient crashing. And in reality, you shouldn't really be RSIing unless it really is something that you need to do rapidly. You should be performing delayed sequence intubation, providing a few minutes of oxygenation, resuscitating. Just failed my national registry today. What do you think is better for studying, pocket prep or one that you recommend? I recommend that you follow the Bossy Paramedic Girl. That Bossy Paramedic Girl, she has a ton of resources for assisting with that sort of thing. That is her lane. And I don't know anything about pocket prep. I do think that Limmer has some great resources for that sort of thing. RSI should always be something if all else fails. Well, I don't like to speak in absolutes like that. I mean, your goal as a paramedic should be to avoid intubation if you can, because you are changing the physiology of how a person is ventilating, and you are potentially introducing pathogens by bypassing their own natural filter system, although, you should have filters in place. And you can introduce barotrauma to the patient. You can introduce ventilator-induced lung injuries, all sorts of things. So obviously, intubation is not necessarily your first choice. However, there are certainly pathologies and injuries where the first thing you want to do is take the airway. So it's not binary. Hey, OnShift in Columbus, just wanted to swing in and say hi and thank you for the content. Huge fan. Thanks, Paul. I appreciate it. Lifted a patient today using my legs instead of my back, tore my calf muscle. See, proper lifting techniques are bullshit. What's your opinion on every cop giving Narcan to people that are unconscious? I mean, it saves lives. I think we need to stop nitpicking cops for giving Narcan to people. Let cops give it to every person they come in contact with. I don't give a shit. There are more people alive today because cops have Narcan. Period. End of discussion. I say end of discussion, but I'm going to keep discussing. Them giving Narcan to people that are unconscious and they can't explain why that patient is unconscious, or maybe they can explain it, but they don't have a lot of confidence in themselves to back up the explanation. Them giving Narcan is saving lives. It is saving lives. Cops having Narcan is saving lives. Your parents, your siblings, your children, you, your wife, your husband, whatever. There's examples of all of you who are walking around on this earth today because a cop gave you Narcan. And we need to stop trying to like push this in a different direction. Well, they should learn how to do this and they should learn how to BVM. No, they fucking shouldn't. Give them, well, I mean, it's great if they learn how to BVM, but they should give the Narcan first. And full stop. Would you extubate a postcode with Ross coming from a standalone surgery center to an ER? It depends. Someone who is, if they are ventilating on their own, but there's no indication of any neuroactivity, then no. If they're trying to yank the tube, then yes. But, I mean, I would call, because most services don't have an extubation protocol. Some of them do, but most of them don't. So you just call and say, hey, this guy's trying to rip out his tube. He's literally looking at me and going, so, And in that situation, if a patient is trying to rip out their tube, then in that situation, it's just better to ask for forgiveness than permission, right? We don't want them to damage their vocal cords. So if the patient's literally fighting you, that patient has a very delicate heart, right? They have a very irritable heart, and it's probably best that we don't overstimulate them, and we don't necessarily need to knock them out either. So, deflate the cuff, let's pull that tube and keep them nice and calm. But if they're at risk for aspiration because they're unconscious, then no, I wouldn't pull the tube. Any tips for me going to medic school in January? Yeah, start reading your source material now and make your drug cards now. So alternate between reading your source material and studying your drug cards. If you can memorize a lot of the medications that you'll have on an ambulance as a paramedic now, it's really going to help you in school. It's one of the single largest sources of rote memorization, and it's a huge cognitive offload to get some of that rote memorization out of the way before you actually get into class and before you start pharmacology. And just read your source material. If you've gotten 2 reads on a chapter before you get into your actual class, then all you have to do really is just read it one more time and do some highlighting. And if you can just do that for every class and just stay ahead of your reading, you're going to sail through. Have you ever had a paralytic just not work, even when the IV flushes without infiltration? I haven't. Patient tubed in surgery center and started bucking the tube after ROSC achieved. Yeah, if we're talking about bucking the tube in that they're just breathing against you, then maybe some light sedation is the order of the day. But, if they're literally making some deliberate movements, in kind of gesturing towards wanting to grab that tube, I would be more inclined to think about extubation. Agreed. Being proactive with RSI. Patient crumped for a reason. It's like H's and T's. Yeah. I mean, you got a guy, who's in who's experiencing severe pulmonary edema, CHF patient's been out of their meds for a while, and they're literally just like spewing frothy white sputum at everyone, and they're like guppy breathing. That patient just, that patient needs to be tubed. They're beyond CPAP or BiPAP, right? But, there's some other pathologies, COPD patients and stuff like that, where if you manage that properly, you can avoid a tube. I just want them to stop giving 20 milligrams in 5 minutes. I'd rather they do that than not give it, though. Yeah, I mean, that's you got to remember that people who aren't trained medical responders, one of the things that you start getting good at as a medical provider is like understanding the amount of time that's passing. People who aren't medical providers, it's like, every seizure patient has been seizing for 5 to 15 minutes. And in all reality, if that actually happened on camera and you go back and look at the footage, most of these seizure patients don't seize for more than 15 to 20 seconds. So, police are just like everyone else. They lose track of time. And when they give that Narcan, it may seem like it's been 10 minutes when it's only been 45 seconds. If cops give Narcan once nothing happens, they should stop there. No, give at least one more Narcan. I mean, there are some people that just require more than that. And it's not even about how much Narcan that they require, as much as it is that intranasal Narcan is an imprecise delivery mechanism. Somebody can have gross contamination of the nasal passages. They have a lot of hair in there. They have a lot of secretions, and that doesn't absorb very well. And it also depends on which way you're pointing it. Sometimes it just drips down into their oropharynx, right? So sometimes it actually takes like 4 administrations of Narcan before it actually saturates something enough to start absorbing. So it's not necessarily about the amount of Narcan they've gotten as much as it is about how much they've needed to get it to start saturating, or just the third Narcan was the one that was pointed in the right direction. I would rather that I wish we had Narcan auto-injectors, because IM delivery is the best delivery for Narcan. It's the most stable delivery mechanism. It's a slow absorption. It's a nice, steady, slow absorption. The patient wakes up nice and slow, and usually without the undesirable side effects that you would get with intranasal or IV administration. And when I say IV administration, I mean boluses, not titrating it by a drip. If someone's trying to yank their own tube, there's not enough sedation. Well, we usually don't start with sedation and cardiac arrest, right? So if somebody post-ROSC is trying to yank their tube, that patient may fare better from being extubated than they are from being sedated. They are in a very precarious spot right there. And, they need something that isn't going to, blunt their cardiovascular capacity. They need something that's not going to overstimulate their cardiovascular capacity. So they're in a weird spot right there, and sometimes it's worth extubating them. I've had plenty of patients that were cardiac arrest patients. We got ROSC, and 10 minutes later we're having a conversation. I'm sure everyone has had that patient at some point or another. That patient didn't need to be paralyzed and sedated. They just needed the tube out. That's a great question. What are the hardest chapters in medical school that I can get a head start on? I'm sure everyone would want to say something like cardiology, right? Cardiology is underserved in a lot of paramedic programs. I know paramedic programs where the entire cardiology module is dealt with in just a couple of days. Could you imagine your cardiac module being a couple of days? My cardiac module took place over 2 months. And I still felt like I had so much more to learn. But the most challenging chapters in medical school are your medical chapters, because there's just so freaking many of them, and there's just not enough time. So if you are ahead of the game right now in medical school and you have the luxury of time, then read your medical chapters, because the return that that's going to provide you is invaluable. Treatment for hyperkalemia. Well, the field treatment would be primarily calcium, because calcium stabilizes the cell wall membrane, but also treating the cause of hyperkalemia. Sometimes hyperkalemia can be caused by something else, like in DKA. Hyperkalemia is caused by metabolic acidosis. In metabolic acidosis, hydrogen ions get really pushy, and they barge their way into the cells, and they push potassium out of the cells. And so when you resolve that metabolic acidosis, then those hydrogen ions come out of the cells and the potassium goes back in. But calcium, bicarb, Intranasal Narcan works slower than IV. IV, provide appropriate ventilation. It does, but that's why I advocate, if you are a ALS responder, I advocate for IM administration. It's a really stable way of delivering Narcan. What's your opinion on EMTB being able to use CPAP? I am all about it. We're just getting to the point where CPAP is mostly a no-fail intervention. There's very few times where you're truly going to be concerned about inappropriately using CPAP. But, it's going to require some education. It's not like, okay, basics get to use CPAP now, but basics get to use CPAP all over the country, and we're not hearing horror stories of basics killing people with CPAPs. What are the studies showing in regards to amio versus lido as antidysrhythmics? So the data there's a lot of heterogeneity in the data there, meaning that there's conflicting data, that it's not in complete agreement. I think it's generally agreed upon that they are beneficial as antidysrhythmics, but just barely, and probably more so when given early. Amio has kind of the edge on out-of-hospital cardiac arrest. Lidocaine actually tends to have the edge on in-hospital cardiac arrest. Just wanted to say thank you for your content. I like the nuts and bolts approach. Thank you. I appreciate that. IM Narcan is the bomb. Saw it was awesome. Yeah, there was a study done. It's been about 4 years now. It was the first true random control trial involving intranasal administration of Narcan. Previous to that, they just loaded people up with opiates, gave them intranasal Narcan, and said, look, it works. So this was one of the first true RCTs done with people out in the field that had actually suffered from opioid toxicity, and they studied different routes of administration. Intramuscular Narcan was associated with far better outcomes. And when I say outcomes, I mean that they had far fewer side effects. And it worked, I think it worked quicker than intranasal, if I'm not mistaken, but that wasn't important as the fact that there were far fewer unwanted side effects with intramuscular administration. They have taken away cardiac medication down the tube for us. Thank God. No one should be giving cardiac meds down the tube. We have IO is a thing. You don't need to be given cardiac meds down the tube. We just were drowning people that way because what you had to do was administer the med and then chase it with 10 milliliters of fluid. So after 3 rounds of ACLS, they were drowning. I see the push for blood on field. Curious with blood short shelf life. Why not expanders? It's not just about volume, it's about oxygen carrying capacity. That's why. And clotting factors. I really want to become a paramedic. Someday, and I'm starting out EMT school. Any advice? Focus on your EMT right now and develop good study habits, develop good friends who are smarter than you, develop relationships with other providers who are smarter than you, and prioritize your time. Anytime you have the opportunity to study and you choose to do something else, you are stealing your success away from yourself and your program. I know we all want to go out and hang out and drink and party and scroll our phone and watch movies and all this sort of stuff, but when you commit to your school, that stuff's got to take a back seat. It really does. That's right. Being a good EMT is the first step to being a paramedic. Absolutely. I got about a half hour to go here in my shift, although, I mean, really, in about 10 minutes or so, I need to end it. But I do 4 days in a row, and then I get 6 days off. But I'm feeling it at the end of my fourth day, which is today. Woo. Thoughts on mass trousers. I don't know. What's your thoughts on leeching people? So the data on the mass trousers that we got was that it did not displace as much blood as we thought it did consistently. It consistently only displaced about 5% of blood volume, which was not enough to impact patient outcomes. And patient outcomes were unaffected by the application of mass trousers. So, see ya. Thank you for the follow, Pink Pillow 45. If you have the national test, why can't we have national standards? Because the Constitution, states have rights to operate the way they want to operate, and so we would be violating the Constitution by attempting to nationalize EMS. Now, that doesn't mean that we can't have an EMS compact that has national standards, but as far as just telling the states we're going to nationalize this, that's not constitutional. What time is it for you? It's almost midnight where I am. I'm in Atlanta. 9 p.m. where I am. What are you, in California? I'm going to be in Bozeman, Montana next week for Heavy Lies the Helmets Crash and Learn Critical Care Conference. I cannot wait for that. Going to put out a lot of content from there. Hopefully stuff that you guys like. So I remember you did a video on IM Epi during cardiac arrest and the video about poor neurological outcomes in IV. I did both of those things. Are there better neurological outcomes with IM? So we don't have a lot of data on IM administration of epinephrine in cardiac arrest. There was this one service that published their one paper, but they did show improved neurological outcome with IM administration of epinephrine, and that was 5 milligrams of IM, 5 milligrams of epinephrine. So there are studies ongoing now looking at this on kind of a grander scale to see if the juice is actually worth the squeeze. Can you use cardiac epi for anaphylaxis? I mean, you can. What you would do is you would administer the intravenous dose equivalent to what your intramuscular dose would be. So, 3 milliliters of your 1 to 10,000. Now, that's not his first line. That's when the patient is refractory to the administration of 1 to 1,000. And follow your local protocols, please. We got Domino's using jetpacks. How soon before we see AMR, jetpack medic? Well, the purpose of EpiPen is to give them a set dosage. And we really don't need to customize doses too much for epinephrine for anaphylaxis. They either get 0.15 or they get 0.3. Depending, and there's a cutoff for the age, so or weight. But it doesn't need to be complicated when it comes to IM epi administration for anaphylaxis. I mean, if the actual usage of the pen is complicated, then that's a problem. Any advice for newly qualified paramedics? Get right into a critical care course and start cementing what you've learned and building on it with critical care concepts. And then don't stop learning. Like, get on social media and find other learners, connect to them, join learner groups, and just keep learning, and don't get involved with the toxic people in your service. What do you think about the proposed intranasal epinephrine? I think it's called Neffy. It is, and I'm very excited about that. That is another hurdle we get out of the way when it comes to treating anaphylaxis, is intranasal epinephrine. I think there's even a sublingual epinephrine out there. Off topic, but how's your puppy doing? Roxy is doing fantastic. I love that little puppy. My first schnauzer, and she's awesome. Yes, have a group of trusted mentors. Absolutely. And if you're wondering what's going on with my national paramedic national EMS mentoring program, still planning on doing it. I have a list of people who have contacted me. It's just not the sort of thing that we just want to throw together, right? You're connecting people to people they've never met, and we want to have a level of trust there. We want to be accountable. We want to have some set standards, and so, it's going to take a while. Is swelling in the lips and neck considered anaphylaxis? You should treat swelling in the lips and neck as anaphylaxis. Yes. Because that is right there around the airway. Absolutely. All right, guys. It is time for me to pack it up because I am tired. I got to go take some stuff off the truck, put up our narcs and everything. So appreciate you guys keeping up with me. This was a good live. And if you're at work right now, go out and do good work. And we'll see you guys later.